Okay, we're recording.
What's up?
Ready?
Yeah,
Ready?
I'm ready.
Yeah. Sorry, I was waiting for like the
Countdown, maybe.
next, yeah.
You ready to go? You
Well,
can introduce yourself?
This
Space
is it?
Force.
Yeah.
Go
Let me
for it.
Let me get
Introduce
another
yourself.
beer. My name is Ben Doty, and I am a soon-to-be fourth-year medical student at the University of Kentucky. Happy to be here.
You have anything else fun or interesting?
Wish I was sponsored by Miller Lite.
What do you do as a fourth year?
So I will be kind of catering my schedule towards emergency medicine in hopes of doing emergency medicine residency the following year.
My name is Haedan Eager. I am also an almost fourth-year medical student. I go to a DO school in West Virginia. Our home base is in a very small town called Lewisburg. It was named the coolest small town in 2011. So, small town, but I mean, definitely something to remember.
The coolest, though.
Yeah.
Mm-hmm.
So how do you get connected with these guys?
So, I am engaged to Ben. Looks like that was a surprise to a few people.
No.
Maybe Ben.
Yeah.
To all of us.
Yeah.
How long's that been going on
Guys,
for?
surprise. I have a lot of money, and that is why Haedan finds me interesting.
He's so interesting. I'm originally from Georgia. I tell people I'm from Atlanta, but I'm actually from a pretty small town in North Georgia, in Forsyth County. I am a Georgia Bulldog, as is Ben.
Go Dogs.
Go Dogs. Ooh. And we met working after undergrad at Emory Genetics Lab, doing a little bit of genetics research, mostly a desk job for me. And that's how. And we met working at Emory while we were both in that application cycle to medical school and have just made it work. Here we are.
Ben, where are you a medical student at?
University of Kentucky.
Oh, okay.
Yep, so right down the road.
Excellent. So you kind of just roped her into this. So Peter is your mentor. Mm-hmm. You're like, hey, I'm doing a podcast. Why don't you come along too?
Correct. Yeah. I think it was first year of medical school. I reached out to Peter and, honestly at the time, emergency medicine wasn't even on the list for me. And it was for Haedan. And so I thought, I'm going to try and get some more information about emergency medicine. And I knew that she didn't have the same opportunity. And so I didn't even expect for him to reply back because I thought, what kind of emergency medicine physician is going to just deal with some low-level, bumbling idiot like me? And so he responded and said, let's meet at World of Beer. And then I knew from that moment on, I was like, oh, this is like match made in heaven. And he was gracious and kind enough to take me on and show me the ropes. And I'm trying to learn half of what he says. And then I roped Haedan into it too and said, we're doing some interesting stuff. You might want to be a part of this. It's the movement. It's the wave. Yeah. And so
there are not many fellowships that are offered through getting a residency as an emergency physician. One of the few is toxicology. I didn't know much about it until I met Peter. We call him Dr. A at home, so calling him Peter here is really strange.
Call him Dr. what?
Dr. A.
Oh,
yeah.
Okay. I like that.
Ben calls him Uncle A at home, but I wasn't going to embarrass him. Toxicology has been really interesting to both of us. It attracts that investigative side of emergency medicine. It seems to be a pretty small field from what I've heard. And we're both just very slowly dipping our toe in the water. And we watch the news every once in a while. And 2 weeks ago, maybe 10 days ago, we were watching the news and just kind of had this idea of what's in tear gas? What do you think they're doing? What is going to happen to those people? There are all these clips of people pouring milk on themselves or water, and you go online and there's all this information, but no one can really tell you where it's coming from. And I think in about 24 hours, Ben and I did a literature review with Peter's help. Obviously, he did almost all of it, I should say, and put something together. I think that will really help us in our career one day, but hopefully will also really educate other people. We hope it's an approachable way to learn more about a hot topic.
Yeah, that'd be good. We have, physicians, nurses, paramedics, all sorts of different specialties that listen to the podcast. So I think everyone could find it useful. And now let's get an introduction from Dr. A.
Yeah, so I'm Dr. Peter Akpunonu. I'm actually from Toledo, Ohio. Went to Ohio State, the Ohio State University.
Unbelievable.
for undergrad and back to the University of Toledo for medical school. I did an emergency medicine residency out at the University of Kansas in Kansas City, Kansas, and then jetted off to Portland, Oregon for 2 years to do a fellowship in medical toxicology. I actually came back to the University of Kentucky because I rotated here as a medical student and kind of fell in love with the ED, and they needed a toxicologist. And since being here, I've taken over as the medical director for the Poison Center, and I've been kind of just reviewing our protocols and seeing what's going on in the world, and realized that we didn't have a riot control agent protocol and probably needed to do a review about it. And honestly, it was something I was thinking about that I probably wouldn't do until like another couple of weeks. And then I got a text message from my trusty mentor, Ben, that said, we should do something about riot control agents. I said, oh, okay. And so I went into a night shift and did some literature review for them and gave them a brief outline, and they took it and ran with it from there.
That's awesome. If any of my medics or any medic in Kentucky, if they call Poison Control Center, can they specifically request you?
They can. So, fortunately for us, there's actually 4 toxicologists that'll be taking backup calls. So when you call the Poison Center, you'll speak to a nurse or a pharmacist initially. And if you have specific questions, they can request to speak to the toxicologist on call, and they'll usually get you connected about half of the days out of the month, or maybe a few more. It usually is me. So
cool.
Whenever there are questions, I'm always ready to answer.
I would say you get a lot of calls each day.
Yeah, the Poison Center gets a lot of calls. Fortunately, with the way we design protocols and most of the things that happen poisoning-wise, it doesn't require a whole lot.
Yeah.
So our nurses and our pharmacists are pretty damn good, and they keep having me talk to too many people, and they keep a lot of people out of the hospital.
If you specifically want to talk to Dr. A, his address is 556. He loves house calls.
What are we talking about? We're talking about riot control injuries. Is there some sort of categorization for how we should, break this down? So there are like chemical incapacitators, right?
Correct.
And then is that pretty much it when you're talking about riot control agents?
So I guess I would say not it for riot control agents. The ones that we tended to focus on, there are, whether they be repellents, of some sort, with that we didn't really touch on. So I think we mostly stuck with the most common chemical riot control agents.
And were you part of that paper with Dr. A?
Yes. Yeah. So Haedan and I both got lumped on and pitched in, and
I wouldn't say lumped on. They did most of the work.
But yes, we read quite a bit about it and tried to summarize it in our own words and formulate it into something that was concise and easy to read and could potentially be beneficial to most.
In general, if we think about it, if we take like the overarching, the big umbrella would be chemical weapons. It's the way to think about this. But we're not using chemical weapons in the same way that we're using organophosphate poisons or things like that, or even lewisite or phosgene. These are really just dispersal agents. The idea is spray them into an area and get everybody to leave. Make it noxious enough that you want to go, but that you don't want to stay, but not to cause real harm. There's kind of a fine line. There's an area where you think about like incapacitating agents. So if I think back to our previous hostage situations in Russia and whatnot, where they've sprayed an incapacitating agent, which may cause people to pass out or be immobile.
And I think there's also a category of physical repellents that include, I only know them as they're called, I guess in popular media, as the rubber bullets, or I think I've also seen them called concussion bullets, is what there's a little bit of a push to have them renamed for, but we did not talk about that in the article that we wrote. We wanted to stay more in the sphere of toxicology.
Super nerds, keep it to chemistry.
Yeah, definitely.
Yeah, and I think there's probably less known about, how to treat patients exposed to like chemical repellents as opposed to patients hit by a rubber bullet. Does that make sense?
For sure.
So there's a big, knowledge gap between those two things. So when we talk about chemical incapacitators or human repellents or the human chemical repellents, what are some of the names of the most common repellents? And can you just, go ahead and talk a little bit about the mechanism, how it makes them, how it provides such noxious stimuli that they don't want to be near it?
The 3 main chemical incapacitators that we chose to focus on were, and these are long names that I can barely pronounce, 2-chloroacetophenone, which is abbreviated CN, which is also the chemical brand Mace. That was one of them. And then closely related is the O-chlorobenzylidine malonitrile, which is abbreviated CS, and that's commonly referred to as tear gas. And the last one that we focused on was the oleoresin capsicum, which is abbreviated OC, and pepper spray. So those were the three that we felt are most popularly used. CN, not as much anymore because it is quite toxic. And I guess sometimes it borders from non-lethal to can inflict some pretty serious damage. So I try and steer clear of that one now. So CS and OC being the two main ones. And so talking about mechanisms of toxicity, really, I think the best way to think about it is twofold. You got all of these can cause, quick neurotransmission type pain. Getting into some of the details, they have sensory fibers, and these route to the CNS and can result in the quick, like pins and needles type feeling and the burning. And then secondarily, there's also quite an inflammatory process that's going on, and the release of neuropeptides like substance P is a big one that gets thrown around, and OC, the pepper spray, is a big one for that. The active ingredient in that is capsaicin, which is actually an extract of pepper plants that people are kind of aware of. Those tend to release quite a bit of substance P that results in a painful sensation that people experience.
I've got some trivia for you about the OC, which almost all of my medical knowledge revolves around trivia. So sorry to interrupt you, Ben. But
toxicology fellowship is a way to go for you. It's entirely trivia-based practice.
Yeah. Well, you will like this. The substance P that is released when you're exposed to OC is something that humans can build a tolerance to. That tolerance lasts for long periods of time. So if you are a person, say, that eats a lot of hot chicken wings, lots of spicy food, if you were exposed to tear gas next to someone who eats no spicy food, the tear gas would be and by tear gas I mean the pepper spray, specifically OC, would be much less painful for you, as you would have a tolerance to pepper spray, which from a physiologic perspective is the same tolerance you build from eating a lot of spicy food.
So before going out rioting, make sure to build up your tolerance. Eat a lot of spicy food.
I was just going to say that was a very shameless plug for all spicy foods. I think chicken wings specifically you mentioned.
Yeah.
So it's all spicy food. I was thinking it was just like peppers, certain kinds of peppers.
So most of the heat that you're going to get from most of your spicy foods are going to be related to capsaicin from the peppers. Now, obviously, you can get a couple other things that are going to cause that, but peppers in specific will, help you along the way. So start eating ghost peppers before rioting time, and you should be safe.
It's your civic duty, really.
Yeah. Get up there around there a couple million Scoville units, and it'll be all right.
All right. So there were a lot of big words. So can we summarize, like when we're talking about mace or pepper spray, are those two different things? What exactly are we talking about here?
Yeah, I will also throw in some history trivia while we backtrack a little bit. So CN is one of the first compounds that was invented, I think around 1944.
Did they use that in Waco?
The French invented it.
Oh.
World War I time.
It was World War I. And I believe around the 70s or 80s. I don't know about Waco, to tell you the truth. I should have looked that up.
I just thought about it. Sorry.
Don't hold that against me.
We watched a Netflix thing on Waco. We should be experts on it.
We should. So CN was invented for World War I by the French. And within about 20 years of really studying that, I think internationally, everyone was able to come to a consensus that it's too toxic and too harmful. For whatever reason, we now sell it to individuals under the name Mace. You can buy it on a keychain. I can't really make sense of that. But instead, what almost all military forces and police officers carry would either be the compound CS, which we call tear gas, or the number one most popular agent that police officers in the United States carry is OC or pepper spray. So I think you can kind of lump all of these in. I think when you hear anyone talk about tear gas or pepper spray in the United States, they're probably talking about OC. In the paper that we wrote and almost all of our conversations, we kind of group CS and OC together.
Are there any clinically relevant differences?
No. Maybe hypothetically, which I think we have planned to talk about later, but this would be a very, very small chance of a hypothetical situation. But otherwise, all of the symptoms, from what I know, would be pretty similar.
Yeah, I would say, for the most part, I think the utility in lumping a lot of them together is management. A lot of these things are managed in similar fashions. However, the CS, or the tear gas, and the OC, which is the pepper spray, do tend to have a little bit of, what's most affected, a little bit of differences in that way. Like the CS can be quite toxic to the skin. It's dose dependent, so it depends on how much you're exposed to and ventilation, a lot of different factors. But the pepper spray is mostly designed to be like a close contact form of, it's a spray versus an aerosolized thing. So it's meant to kind of affect a smaller number of people and be sprayed directly into the face. So most of those presentations will be ocular and or mucous membranes involved with nostrils and mouth, versus the tear gas, which can kind of disperse and settle and cause more dermatologic manifestations.
Okay, you could just edit out everything that I said, them being the same.
It makes sense to me.
Yeah.
Thank you.
Thank you for that, Ben.
All right. So excellent summary. So I will link to the article that you all wrote in EM Resident in the show notes so that our listeners can take a look at it. But in that paper, you mentioned that CS causes bradykinin release, which may be particularly relevant in the COVID-19 era and also in patients who are on ACE inhibitors. Can you explain that? How is it relevant?
Oh, boy.
Take it away.
You got this, Haedan. We believe in you.
Okay. I will be totally honest before I say anything else. And I want everyone to know that the real reason I put this in here is I hope someone hears this or someone reads it and can make a connection that they can prove in a research lab.
Okay.
We don't know a lot. There's not a lot or any evidence really linking these two things except for in a hypothetical realm. So I hope someone's really inspired by this. What we do know is a lot of people are on ACE inhibitors. It's a normal blood pressure drug. You can use it for a lot of things. There's a very high percentage of the population on those. This receptor, this pathway is involved in something called bradykinin. It's an inflammatory molecule in the lungs. It can make you cough, can make your face swell, your body swell. And this same pathway, the ACE2 receptor, is how COVID enters your cells. We know that, is it OC? Or any of these Riot control gases can lead to a buildup of bradykinin. And so in this very convoluted way that probably doesn't make sense in the way that I just said it, these all have a small overlap of relevance to each other. It's probably not a great idea to have an agent that is incredibly inflammatory in and of itself, but if it's inflammatory in the same way that COVID is infecting your lungs, causing this widespread inflammation in your body, I think we could probably all agree that this could be a cumulative problem that could compound on itself. But there's not any literature out there right now that proves what I'm saying.
And I'll piggyback off that and say that what we were kind of focusing on is that this bradykinin pathway that Haedan was referring to is commonly involved in many different things, but the two most important being pain and dilation of blood vessels. And so there have been studies that suggest, I guess they kind of say that it is biologically plausible that with these ACE2 receptors that COVID or coronavirus is using to gain entry into cells, that also has some effect on the regulation of bradykinin. Whether they, what that means, they're not really sure. But anytime you have dysregulated bradykinin in a pandemic situation, and you also have a chemical agent that we're focusing on and, dispersing on several protesters, what is the link between those two things? Because this is resulting in an increase in bradykinin, and coronavirus may have some role in dysregulating bradykinin. So the interplay between those two things is kind of unknown. And I think we wanted to to kind of highlight what could this mean.
So I guess the questions underneath what we're saying that we're hoping someone somewhere will be able to answer is, if someone is exposed to a riot control agent, a tear gas, pepper spray, and they're on an ACE inhibitor, are they going to be affected much worse than someone else who's not? Is someone who's exposed to one of these agents, due to the inflammation that's going to happen, are they going to be more likely to get COVID because of the process that happens, and not just because they're coughing and around someone who could be sick? We can't answer these questions, but I think that was kind of like the underlying theme of something we wanted to at least touch on without trying to make a statement about in what we wrote.
Sounds cutting edge.
So if you think about it, these agents are designed to be what we call, let's say, less than lethal. Our favorite axiom in toxicology is that the dose is what makes the poison. So if I continue to add more and more and more, I can potentially develop a lethal outcome for someone. And now we have protesters and rioting going on, and with relatively decent infection rates for COVID as well, something that may be interacting along the same pathway. Is there the possibility that, you are out in a group with COVID, you're on an ACE inhibitor or not, and you are now exposed to a riot control agent? Are your symptoms going to be worse? Do we have an increased risk for your mortality as a result of that? Mm-hmm. We don't really know. Is it possible that you're going to have elevated levels of bradykinin, and what does that actually mean clinically? It can't be answered yet, but hopefully someone will. Maybe in the Doty Eager lab, it'll be answered.
Ooh.
And unfortunately for us, who do a lot of reading and not a ton of bench work researching, these kinds of questions haven't been relevant up until 16 days ago, 18 days ago. There hasn't been an issue or this overlap of a perfect storm of things where anyone has really needed to look at these two things at the same time.
Okay, well, if you're listening to that and you have a research lab, then, get a hold of these folks. So let's segue a little bit into the symptoms of exposure. Now, Dr. A, you mentioned that they're intended to be non-lethal. And when you look up the symptoms of exposure, they all seem relatively benign for the most part, except for the respiratory symptoms. So, can you all kind of break down the signs and symptoms? And I think generally you're going to know that someone was exposed to it by the person that was responsible for that, or they're going to be most of the time awake talking and they're going to say someone sprayed me with mace. But what should we look out for?
So yeah, like you said, I mean, the history won't be very difficult to obtain from these type of patients. I'm sure they'll be more than willing to kind of share the story of what has happened to them quite vividly, I would imagine. But most commonly, these things are either sprayed directly into the eyes or have predominant ocular effects. So some of the things that you can look for is eyelid twitching or muscle spasming of the eyelids, so somebody can't keep their eyes open for long periods of time. They got excessive tearing, burning, and kind of blurred vision. And these are all, this constellation of symptoms is what renders somebody what we call functionally blind. So if you were able to do some kind of, advanced testing to test their visual acuity, it should be normal. But these, the blinking, the excessive tearing kind of keeps them from being able to see well. And then you got other, in terms of, these people are just runny, whether it be runny nose, they're salivating a ton. They can have some difficulty breathing and swallowing. And then with some exposures, you can have dermatologic effects, whether it be, kind of redness of the skin or itching or burning sensations. And if they do kind of happen to swallow a lot of these excess secretions, there can be some nausea and vomiting that follows.
Now, they could get actual burns from it too, right?
So typically the burns that we see are more associated kind of with the aerosolization process. So think about something such as CN being fired in a canister. And then as the canister does the dispersing, being nearby is likely to give you a burn, as well as somewhat the general velocity of the aerosol coming across your skin. Although we do see that a few of them can have the dermatologic burns as well, just from extended exposure.
Okay.
So this is why the mainstay is decontamination. And if you think about it again, if your eyes are burning, your mouth is burning, your nose is running, the only thing you want to do is get away from what's causing that, which is why they're perfect for that.
So something else that I think hasn't been touched on is this is incredibly painful. And the pain isn't just because your eyes hurt and you just got pepper in your eyes, which if anyone has ever chopped something in the kitchen and then not wash your hands well enough and then touched your eye, it is incredibly painful. And you really can't do anything other than just wait. But you're suffering. These agents, though, from a pharmacologic level, this substance P that we talked about a little bit earlier, works in your central nervous system. And so from the inside of your body, in your brain, in your nerves, there is pain signals going on. So it's not just that your eyes hurt and that you're coughing and you have this chest tightness, but from the inside of your body, you feel like you are on fire. And obviously that is incapacitating. It's like having jalapenos in your eyes, but also in your spinal cord.
Yeah, when I was in the Navy, I went through boot camp, and we went through the gas chamber, and they had us take off our gas mask and had us recite our social and all of this stuff. And it's like functionally incapacitating.
What was it like?
They actually had us hold our hands like about waist level, palm up, to catch all the snot that was like running down. And I don't recall getting decontaminated. It was like they just took us outside and eventually everything subsided, you know.
Do you feel like you're dying?
I don't think I felt like I was dying. I don't recall it in great vivid detail, but it was not pleasant.
That's a where you've just blocked out.
Yeah. You couldn't see. Basically, they had you just grab the person in front of you, and they had like a train of people set up to go outside.
Would you consider continue to riot after you had been sprayed with all these things, walk through a gas chamber?
I don't think I would be physically able to do it. I'd just say, I'm done. I'm going home.
Yeah.
You know?
Okay.
So you didn't go back to the chamber for round 2.
Yeah.
No.
Well, I think the takeaway there is to try and eat more spicy foods and really gain a tolerance.
Yeah.
I wish I had known this before I joined the military.
To all active military members.
Yes.
There you
This
go.
could be a good business idea. You could mail people increasing. I'm not going to give it all away, but I've got some money making schemes going on over here.
There you go. All right. So, well, speaking of that, I want to talk a little bit about treatment. And I know, the priority, I think, is decontamination. But I'm also concerned about, or I also want to know, can we get exposed even if let's say the paramedics arrive minutes after a patient has been exposed? Is there a risk to us if we touch, if part of our unprotected skin touches their clothes that have been exposed to this? Is there a risk to us as well?
Mm-hmm. And yeah, that's a great question. And I think one of the major promoters of us writing this was the importance of mitigating secondary exposures and, how bad they can be. So the answer to your question is yes, definitely secondary exposure is something that does happen. And when some of these heavy particles kind of settle on somebody's skin, or clothing or accessory jewelry, what have you, and you arrive at the scene, importantly, you need to get them up off the ground to higher elevation if you can, and get these people. So protecting yourself from a potential secondary exposure, the patient's skin, clothing, jewelry, and all can contain those heavy particles on them. So it is important to kind of wear, proper PPE to protect yourself and try and, minimize contact.
So gown, glove, would we go as far to say face shields? Would you say face shields, or do you think like we're not going to be sniffing their clothes or anything, right?
Right.
So, I mean, honestly, what level of PPE?
I would stick with like your Class D. If you wanted to, you could try to go up to Class C, but there's no need for like your level A or your level B gear here. Most of what you're going to be exposed to, if simple gloves, you can add a gown if you want to. You can add eye protection. Admittedly, again, so these are meant to be sprayed as aerosol. So in theory, by the time that you should arrive, this aerosol should be dissipated. And again, people typically move themselves to a kind of further away in a fresh open air environment, so that the secondary risk of you getting, CN blown on you or OC blown on you is pretty low. You're likely to be contaminated from skin. You can be contaminated from their clothing. So you just have to kind of observe your simple basic PPE goals, take care of numero uno first, and then you can take care of the patient.
Okay.
So some of the decontamination literature that we read just talks about open air. If you can put someone in front of a fan or in a well-ventilated area, somewhere windy, that's really what they need. If you have someone in the back of an ambulance, there is a small chance that maybe some of this, depending on the solvent that was used, this could dry on your skin, and then it could dissolve in the air. And now everyone in the truck is potentially exposed. So what we read specifically recommends to EMS providers and police officers, if you have someone who's been exposed to one of these, just ride with the windows down if you can. Try to get something circulating just so that it's not sitting and marinating the air with pepper spray.
So for the EMS listeners, I think that would probably mean turn on your exhaust fan in the ambulance.
Okay.
So just keep the exhaust fan on. Maybe seal the area between your patient compartment and your driver compartment, kind of like we do with COVID, basically. So one question about decontamination. When we typically respond to someone that's been sprayed with mace, we're kind of like nonchalantly, not really taking it seriously, honestly. We'll maybe like irrigate their eyes a little bit with, normal saline or LR. Some places have Morgan lenses. But we're not doing like full body decontamination. But we had that capability, right? We could call the fire department. They could bring some soap. They have lots of water, and they could literally strip the patient down, put them in a kiddie pool, and spray them off, and put some, soap and water. So, should we be doing decontamination to that degree, or should we focus more on like what body system was exposed or has the most had the most exposure?
I was going to say that's going to vary on how your exposure and what occurred. If you're being sprayed by pepper spray, simply one person spraying another person with pepper spray, your likelihood of, getting cross-contamination from another person is incredibly low. And you're right. You can probably just rinse off their face, rinse out. If you've got a Morgan lens, you can Morgan lens their eye and they'll be fine. The concern here again is if you've got someone that's been exposed to a large volume with a canister and other things, they are more likely to be covered head to toe.
Okay.
And may need more decon. Admittedly, if they're not having any evidence of like true ocular injury or true like mouth injury or mucous membrane injury, it's not necessary for them to even go to the hospital. You could probably, if you wanted to, set up a decon tent. If 200 people have now all been exposed and all have a similar symptom, a little soap and water and stripping down their clothes is all that they really need.
Okay.
That being said, if you've got someone who's now having an asthma exacerbation from it, that is someone that is worthwhile to try and do, a little bit of decon with simple water at the site, but you can take them, transport them to the emergency department, or any emergency department can do the remaining decontamination that's necessary. If they're having an asthma exacerbation, that's their life-threatening condition. It's going to feel miserable to them, and their eyes burning are going to feel like that's the worst thing that's going on, and that's your life-threatening condition. But if you can't breathe, you can't breathe, and there's nothing, you have to treat that immediately.
Okay.
And I think, Doctor, I hit the nail on the head there. What, you said you don't really get excited about a pepper spray, a call maybe. And it really, catered the treatment to the exposure that they said they've received. So, all things being said, if somebody was sprayed with pepper spray, they might think they're going through hell. But give it 30 minutes without any treatment, even if you don't irrigate their eyes or whatever, and that should resolve. And so, but like he was saying, if somebody has been, sprayed with some sort of canister, or they have, vapors that have kind of covered their whole body, that's the type of person. And I think when you get that call and you arrive and you take that history from them, somebody you want to be a little more careful and really decontaminate put clothing into double sealed bags so you minimize your exposure, work on irrigating eyes if that's a symptom or a complaint that they have. And then also for those individuals, if they have been, hit with a canister, sprayed close range or something and are suffering from burns, another important aspect is to remove jewelry and clothing, so that you can really assess the degree of burn that they may have sustained. So I think that's another important aspect of kind of derobing them if that should occur.
Now, when you're decontaminating them, we've already mentioned soap and water. We don't really carry soap on the ambulance. We might be able to get some, if we're close to the patient's house. But would just copious amounts of water work? Because, I did read that water can actually exacerbate it, make it worse. But isn't dilution the solution to pollution?
That's exactly it.
That was
you just stole my phrase. That's
next question.
That's all we had. Yeah. So in the ideal world, you'd pick something that is going to, dissolves something that's going to bind the same molecule and pull it away. That's not really an option in this case. What we do have is water everywhere.
Yeah.
Like you said, fire department has access to a lot of water.
Yeah.
And, there's water anywhere you can be. People always have bottles of water and other things. So while it may not be the perfect solution, it will be sufficient and it will work. Again, these are designed to really only incapacitate you for 30 minutes, maybe an hour, maybe if you continue to re-expose yourself from your hands because you haven't decontaminated longer, but copious amounts of water for a little while to relieve your pain, and you're naturally going to get rid of, your exposure here and start to get better.
Yeah, I think they'll probably be better by the time we get to the hospital.
For sure.
So,
Yeah.
So I think I had when we were doing some investigating, just some background research before we wrote this article.
CSI type stuff.
Yeah. I knew the theme song for that. I don't know. You can really get into a rabbit hole on Google about what is the best way to decontaminate yourself or someone who's been exposed to this. And in that rabbit hole, you can look into structure of compounds. Is this lipophilic? Just all of these crazy things. Everyone is right that we all have water. Water is the best thing to use. There are some small studies that show milk, baby shampoo, vegetable oil. There's many things that you could use. Milk kind of has some questionable. I read from a Twitter famous ophthalmologist that he recommends against milk.
really?
Yeah. Actually got into a Reddit argument with someone about it.
Well, there you go. So if
Yeah.
you're a protester, just good old-fashioned water. And you know what? If the police steal your milk, then joke's on them, right?
Don't cry over it.
Yeah.
Just go out. Haedan Egar's out there. She's ready for a fight on Twitter or
Yeah.
Reddit for you if you need it.
Absolutely.
I mean, the idea for milk kind of extends from what you initially know, right? If you eat something that's too spicy and you go and grab water, it's cold for a minute, but then, man, it seems to feel worse immediately afterwards. You're like, oh, the cold's gone away. It's not getting any better. So what do? You run to the fridge and you look for ice cream or you look for milk. Casein's a protein that's in milk that is very good at it's similar in structure. It's a lot of hydrocarbons, and God, I hate chemistry. Just like capsaicin. So, if you think about like dissolving like, that's why milk works so well. You get this into this more organic layer and kind of pull it away from the receptors that you have. But that being said, if, you ate a ghost pepper and you start just absolutely chugging a gallon of water, eventually you're going to feel better. You're going to dilute that down and it'll be okay. And water's a lot easier to find, especially when you're out riding.
Now, don't they say it's impossible to chug a gallon of milk?
Yeah, I'm fairly certain I had a couple friends in high school that tried that. Did not go well for them either.
Yeah, I can also vouch for. I would never personally do anything like that. That's silly, but
You should check out Ben's YouTube channel.
yeah, that's true. Yeah, plug.
We're gonna mace him next week.
Yeah, we on the next episode. I also know some people that attempted to drink a gallon of milk and it did not end well.
Is bicarb something that's carried on most EMS trucks?
Yes, and it's usually given very irresponsibly.
Okay. The military handbook that I spent most of my time reading, preparing for this, just kind of as a very small sentence, recommends that in the military they use bicarb.
Just
as a
spray the
flush.
patient with bicarb? Like,
Yes.
Okay.
But even that being said, even though there's all these kind of fun and interesting things you could use, at the end of the day, from everything we've read, we would still say that water is the best thing. Lots of water.
that might be the only thing that we have evidence for when it comes to bicarb.
I think there's a few other things.
I
can think of a handful of other things that bicarb may be useful for.
What about a wide QRS complex and a TCA overdose?
Yeah, I'd go bicarb there.
TCA overdose. Hyperkalemia, it's controversial.
Yes.
TCA overdose, definitely. But just routinely given it on cardiac arrest, probably not.
But it sounds,
DKA.
It sounds so cool.
Yeah, it does.
Just give me a bicarb.
Amp a bicarb.
Yeah.
My bicarb knowledge stops at baking soda versus baking powder.
Also in your article, you mentioned that CS can be metabolized to cyanide. Is that true? Is it common? Should we even talk about it?
I wrote this, so I'm going to be the one to defend it.
She's throwing bombs into our paper.
This also...
Snuck that one in there.
I should have proofread this better.
I also got into an internet fight with someone about this. So...
Hold on one second. So were you on Reddit and you shared your own paper?
Absolutely.
And you're like, hey guys, check this
Yes.
out. What do you think of this?
Yep.
And then you just start arguing with them.
someone
and
was
you got
like,
mad.
well, I did the math.
Shameless self-promotion, and I love it.
Yeah.
Take this. There were a whole bunch of people that liked it.
Words you never want to hear is someone say, well, I did the math.
Oh,
And
my
I
boss
read
says that all
and
the
was like,
time.
oh, no. So, before we get into that, this is a military handbook that gave us this information. I believe it was from 2007. So, I'm not sure. You can say that that's outdated or not, I guess, depending on how old you are. But they did an animal study where they gave CS in a lethal dose to animals, either peritoneally or by IV. And these animals still died from lung toxicity, from lung damage. But when they did lab work, there were amounts of cyanide in their blood. And so the military handbook states that you need to be aware that in a scenario where someone is exposed to an extreme amount of CS, it is theoretically possible for them to have cyanide in their system, and that someone somewhere might need to be aware that they need to be treated for cyanide toxicity. One of the hypothetical examples that this could maybe happen where someone could receive this much CS would be someone who's maybe incapacitated on the ground. All of these riot control agents are heavier than air, so they sink to the ground. And the lower you are to the ground, the more you're going to inhale or be exposed to. So I had been thinking, even though this is a small chance, what if something weird happens where there's a ton of this dispersed into the air and there's someone on the ground and they can't get up and they inhale this? Someone somewhere might need to know that you might need to treat them for cyanide toxicity. Someone did the math and told me that this is nearly impossible. In any hypothetical situation, it would be incredibly unlikely. However, weird things happen all the time, things that you don't think should happen. And we felt like it was at least worth mentioning that someone, somewhere, somehow might need to know that CS, even in a very small part, can be metabolized to cyanide.
I mean, it's been used in chemical warfare type situations before, right? I think I read that in the military manual. What was it called?
It had a long name.
I'll put it in the show notes. I'll link to it.
It was really interesting.
Yeah. It's a good manual, I think. Sure.
I wouldn't go grabbing the cyanide kit for anybody right out of the gate. But if you've got someone who's been exposed and was on the ground and doesn't really seem to be responding or improving as you expect, either in the ambulance on the way back or, even if they've made it to your ED and there's still just some things that just don't look right, it's worth a consideration to keep in the back of your mind.
What if you're having to like resuscitate them?
Exactly. Like if you're resuscitating someone and lactates are sky high and they're hypotensive and it's not getting better, and you know that, you know, they were out rioting or they got exposed to CS at some point and other people aren't as sick, but they're still sick. It's worth keeping in the back of your mind. Could this be, you know, cyanide? Could this have been a result of their exposure?
I think, you know, something else that I read is, and this might be a little more common and something that we might see. What about if a patient has reactive airway disease, if they have COPD or asthma, is it pretty common for them to have exacerbations from exposure to these types of agents?
Yeah, that's a very good question. And I think, you know, anytime somebody has some inflammatory or reactive airway disease process, those folks are a little more primed, you know, to have some irritant that can kind of exacerbate their symptom. Would I say it's common? I don't think there's enough literature to support that this is a very common thing. You know, all of those people walking around with well-controlled asthma, if they get exposed to a tiny amount and, you know, happen to inhale that, I don't think that's any reason to get super excited about it. But it definitely has been recorded, and it is something that's important to consider. You know, if you have somebody that comes in that seems a little worse than all their other peers, you know, that were at the same riot, and they say that they have asthma and it turns out that it's poorly controlled, you know, that's somebody that you might need to pay a little more attention to and be, you know, ready with your, you know, those people might require beta agonists and corticosteroids, and people that you might need to treat their reactive airway disease because now their primary problem is their asthma exacerbation versus what they may have been chemically exposed to.
And it would be treated just as you would your standard concoction for reactive airway.
I would, correct.
Yeah, I mean, just to think about this is, if you make it as simple as possible, this is a group of people that have pulmonary disease, and these are pulmonary irritants. So if anything else, I would definitely be worried about their COPD and their asthma. Do I expect this to be the thing that is going to, you know, trigger them off? You tell me that you were in the back of a group of protesters that got sprayed and, you know, maybe your eyes hurt a little bit, but you left. I don't think so. Were you in the front? Did you catch the brunt of what was being deployed? Maybe your asthma is probably going to make your response a lot worse. You're already likely to be, you know, hyperreactive to a pulmonary irritant. Here's another pulmonary irritant.
Another important consideration is, you know, in these times as states are kind of reopening in the midst of COVID-19, are these asymptomatic people that might be out there, is a pulmonary irritant something that could take your asymptomatic patient and now make them symptomatic? And furthermore, there was an interesting study that we read, and I think it was in military recruits, and they, as part of a like integrity test for mask fitting and such, they were exposed to large amounts of CS, and then they were followed for the next week. And those people were, I think the relative risk on this was 1.79. So they were almost twice as likely to get some sort of respiratory infection, whether that be a chest cold or a pneumonia, in the following 7 days. And so what implications that has for those that are getting exposed now? Are they now more likely to manifest some, coronavirus, or they're also doing things, they're taking off their masks, they're yelling and shouting, they're wiping eyes because they've been sprayed with something. So I think the implications for, increasing cases that we're reporting is something also too that is going to be quite interesting to follow. Now,
would wearing a surgical mask or an N95 respirator be protective?
You have an aerosolized solution, so anything that you're going to put over your face is going to be better than nothing. Do I know offhand whether, putting on an N95 like an N95 mask or an N95 respirator is going to be protective? I got nothing for you for that one. I mean, I would expect that since this is an aerolized solution, you're probably going to be more in favor of something like a P100 mask or something, and it will be decidedly more protective for you.
Maybe they should just get cappers.
Exactly.
Or pappers and just start.
Everybody should have pappers.
Yeah.
I mean, that's the way it should be.
I had actually wondered when looking at clips of these protesters that get sprayed and just look so uncomfortable. Why isn't everyone out there? I guess it's been hot lately, but ski goggles, pool goggles. something has got,
Yeah.
there's got to be everyday home equipment that could help mitigate a little bit of this, but
I mean, I guess if you're going out riding, you're not assuming that you're going to get sprayed with pepper spray on that given day.
okay.
And,
Yeah.
That's fair.
you know,
Hey,
I'm thinking the guy next to me is, but not me. I'm hanging out a little bit further towards the back.
exactly.
Like,
Yeah.
They're starting to introduce legislation to like make it much less common. So
To use
Really.
yeah,
agents.
yep, I heard that on NPR. A bunch of states are doing it. It'll like require permission from the police chief and a bunch of higher ups before they can use it.
Was that a?
should have the poison center director to that list.
I was gonna say, yeah.
I'd love to be
I know
on
a guy.
that list.
Yeah.
Was it somebody out of Duke that they were interviewing and talking to on NPR?
I don't remember.
think
It was this
okay.
morning on my way to work at
Yeah,
like
I think I read the same thing, talking about how this is adding fuel to the fire, kind of a deal.
One of the things I've seen floating around just in discussion and even talking with people is that these riot control agents, tear gas, pepper spray, are against the Geneva Convention. You can't use these in warfare, which is true. But it's not because of what I thought it was, not why I thought. It's not because it's inhumane and this is such a terrible thing to inflict on other people. But the reason that you can't use these in warfare is this risk of enemy elevation. I'm not totally sure of the proper term, but the risk of you deploying tear gas on someone else, them not knowing what it is, and them tossing back something that is deadly, will just destroy the earth and everything near it, is so high that you can't use chemical weapons in war, which is why it's in the Geneva Convention, but it's not because it's so terrible to use on human beings.
That makes sense.
Yeah, you don't want that horrid escalation. I sprayed you with CN, now we're spraying lewisite or phosgene back, or
Or carfentanil.
carfentanil, or VX or something to that effect. I mean, that's if you remembered Waco, that is one of the scenes where they're pulling out. They arrive and they have CN, and one of the officers are saying to someone else, like, the Geneva Convention says that you can't use this, and the Geneva Convention only applies to wartime.
Interesting.
I think I saw the lights that they looked like they used at Waco. The annoying lights.
To disorient.
Yeah, on the lawn of the White House, it looked like.
Really?
Ooh,
Maybe.
Dang.
Just my Netflix knowledge right there.
All right. So, wow. I think we pretty much covered everything. Do you all have anything to add? Anything you think people should know?
I have two.
Okay.
One thing is specifically for EMS. Is EMS providers the right
Yeah.
phrase to use?
Sure.
Okay.
what you can't do is call them ambulance drivers. That is a big no-no.
The ambulance drivers?
Yeah. No. Solid no. But
That's what they call
EMS
them around
providers.
where I come from. Okay. So specifically speaking to EMS providers, I talked about this earlier, but these gases are heavier than air. And so if there's ever a reason where you're needing to drive to a place where this is being deployed, if you are able to look at the landscape and park as high up as you can, that's the safest place for you to be, for you and all of your teammates, and then eventually for the patients that you'll be taking with you. But
you can apply those basic hazmat principles about staying upwind.
oh,
and
this is
everything
something
else.
you guys already know. This isn't old news.
Uphill, upwind.
Uphill, upwind.
Yeah. Don't want to be downwind.
Same thing
That's
goes.
a firefighter's job. We just, not us. Sorry.
It's all the practical stuff that they don't teach us in the med school textbooks.
But no, it's a good point. It's good to reiterate. And also with the patients, if they're on the ground, get them
right,
up.
absolutely.
You know?
Yeah.
Definitely.
And then the other thing, just some of the red flag kind of patients that I think most ED physicians would want to know about, want you to mention in the handoff. Something like someone that's just different from everyone else, like Dr. A mentioned, or a COPD asthma patient, but also someone who is having eye symptoms and complaining of maybe not being able to see, or their eye problems are just worse than something else you would expect to see. One of the red flag history examples that we'd be looking for is someone who's been sprayed really close, because hypothetically, these should not be able to blind you. They should just bother you so much you can't see well. But some of the particles that are mixed with these tear gases can get chunky, for lack of a better word. And if you're sprayed really close, these particles can irritate your tissue enough that it could potentially cause blindness. And for any of the emergency people out there listening, someone who's been sprayed really close in the eyes is an automatic ophthalmology referral or consult.
Do you think we should pull out the slit lamp on our ambulance and inspect eyes?
Ooh. I did not know that was something.
It's not. I'm kidding.
Oh.
I'm kidding.
Every opportunity you get to look in the eyes, go for it.
I was just going to say, if that is a capability, then yes. Yes, you should. And let us know what you find.
Yeah.
I'm just kidding.
Can you give me one?
No.
I think one thing that I definitely want to mention is, we tend to spend a lot of time focusing on worst case scenarios and, what to do if, and you take this, a relatively benign agent that's meant to get people gone quick. And we paint this picture of it's an ABC patient, somebody that you need to, cover their ABCs and resuscitate. But generally speaking, these are patients that if you did nothing for, they would get better on their own. And so, we wanted to write this and say, this is what could go wrong. And these are things that you could see. So be prepared for them. All of that being said, for EMS providers and emergency physicians alike, most of these people with a little bit of decontamination will do just fine, and all in the span of less than an hour.
So has blindness occurred? And if it has occurred, like permanent blindness, have people that have been exposed to this became permanently blind? And if they have, are there any cases where it was not a result of them just getting the physical impact of the chunky stuff that's not actually aerosolized very well? Does that question make sense?
Definitely, yeah.
So can it cause even just copious amounts? Can it cause permanent blindness?
Mm-hmm. And I think the answer to that is just the chemicals alone. No, they cannot cause permanent vision loss. However, like you said, an important factor in that is, were they close to something that exploded? Or were they also hit with solvent particles that this was, put into a canister with? Those folks have been reported to have permanent visual loss. But in terms of documentation, if you're just, exposed to a regular dose of pepper spray, there have been no reports of blindness following that.
You're looking for something that break a little bit of that physical integrity of the eye. And that surface area. So a lot of them, if you think there's a few formulations that you can use for dispersal that disperse on contact. So you're essentially firing, think of almost like a paintball, and then disperse on contact. So if you catch that close to the eye, now you have a physical injury to the eye. And now you have chemicals that have broken through part of that barrier that can cause you to have some blindness there. Not to mention as well, just being physically struck with the object that may lead you to have blindness. From my standpoint, from the emergency medicine kind of area, the things that I want to know are, where was the exposure? I want to know whether you were indoors or outdoors. These are meant to be used outdoors. To say that they haven't been used indoors would be a lie. And that your risks are going to be much more in an enclosed space than out in open air. History-wise, what I want to know is, do they have pulmonary complaints? Do they have pulmonary issues at baseline? And then I also want to know what you guys see when you're there. If there's a riot and there's an exposure for a riot control agent, I don't expect to see people that are coming in with diarrhea, that are super sweaty, that are drooling and having runny nose and everything else. You're making me more concerned for a nerve agent exposure than at that point than an actual riot control agent. Or if you tell me that, yes, this is a riot control agent, and you walked out and everybody was passed out on the ground, that's not what we're expecting here. That's someone spraying, they've done this with benzodiazepines and fentanyls and other things in the past, and that requires something entirely different from me. Decontamination is still important, but now we're moving into the antidotes instead.
So what is your litmus test for who should go to the hospital and who should not, if you had to develop one?
If you have someone that has burns, we talked a little bit about vesicles and dermatitis. Is that the kind of patient you want to see?
I would want to see that, because I know that some of these can cause vesicles on the skin, but if you're telling me that someone has vesicles over a large area of exposed skin and was not particularly close to the dispersal agent, that's also a concern for me. That sounds like a vesicant gas. It sounds like an arsenical or something that I need to be a little bit more worried about. Fortunately, I should say, knock on wood, that has yet to be a problem for us here. But, that's one of the big troubles that we have, even related to hazmat, is, someone tells us it's something benign, only later to find out that it is something more toxic and more concerning. Who do I want to see in the ED? I want to see someone that's having persistent symptoms, someone that's got a history that is going to be concerning. If you pulled someone that was found down on the ground, I want to see them in the emergency department. If they're wheezing and having trouble catching their breath and, it's likely before you arrive, it's likely been 30 minutes. I want to see that person. The person says that they can't see and it's been an extended period of time. I want to see that. I want to know that they don't have an actual physical injury to the eye.
I don't think you have to worry because the police will say you can go with us or you can go with them.
It's a pretty easy choice at that point.
Yeah. So awesome. Thank you all so much.
Yeah, thank you for having us.
For coming on the show. I definitely learned a lot and I hope that all of the listeners did as well. Now, if they have any questions for you all, is there a way for them to connect with you on social media, or is it mostly personal, your social media platforms?
So I have an Instagram page. I will not fight with you. I mostly put my art. It's mostly geared towards my professional medical life. You can find me on Instagram. It is rule number 13. I'm a big House of God fan. But then we can also send our email addresses for more personal.
Well, if anybody has a question, they can just email me and I can...
Absolutely.
Or I can just ask them to comment on the post on Facebook or Twitter. Do you have Twitter?
I do not have Twitter.
Oh, you have to get Twitter.
I should. I
am a twit.
They can,
Twitter is awesome.
Yeah. Haedan can filter and show me tweets or something. Or maybe I'll get a Twitter because of this life-altering moment.
Yeah.
That's what I did. I finally had to cave and switch over to a more professional Twitter.
Gotcha. Okay. Yeah. Well, then I will Twitter handle pending.
Okay.
Is what I should say.
It's the hardest part.
Yeah. Now I got to go to the lab,
yeah.
I think.
We can update the show notes when it comes out.
Perfect.
All right. Well, that is all for now.
Thank you.
Thank you.
All right. Bye.